to the Evolving Past Alzheimer's podcast, where we are focused on bringing you information to help prevent and reverse brain diseases like Alzheimer's and other dementias. I'm Dr. Nate Bergman, a functional medicine physician in Cleveland, Ohio, and your host on this journey. So, whether you're a baby boomer who's worried that your brain wiring just isn't working like it once was, or you have loved ones with the disease, or you yourself have already been diagnosed and are wondering, what do I do now? You'll want to listen to this podcast. Each episode, we introduce you to the top doers and thinkers that are revisioning Alzheimer's and dementia. If you have questions or comments or just want to connect, please check us out on our Facebook page, or if you're old-fashioned like me, Google Evolving Past Alzheimer's Podcast, and you'll find us that way. So here we go. Let's get better. Welcome back to the show. We have another couple of great guests today. Today we're speaking with two guests from the Netherlands. We're speaking with Elisa Luijmes from her parents' home and Sjaak Pouwels, MD, PhD. I think he's currently in Rotterdam.
Yep.
Thank you for joining us both.
You're welcome.
Yeah, you're welcome. Thanks for having us.
So Robin is a developing psychologist, and she started working with patients with acquired brain injury. Wanting a broader knowledge of the psychological impact in patients with a variety of medical conditions, she ended up completing her training as a medical psychologist, which she's currently doing. And while working in a hospital there in the Netherlands, she met Dr. Pouwels, who is himself an aspiring and highly motivated young research physician. He's an MD, PhD, currently finishing up training as a surgeon. Because of their common interest in neurobiology, they published an article together that was published in 2016 called The Effectiveness of Neurofeedback on Cognitive Functioning in Patients with Alzheimer's Disease. And this was preliminary results period. So can you guys first tell us, Robin, what this interest that you had in working with patients with brain injury was and how you and Dr. Pouwels hooked up in this project here?
Well, it started a few years ago. I always saw patients and they had some deficits and I didn't clearly understand what it was. So that's what got me hooked on the neurological side of psychology. And after working with that, I didn't see a lot of effects. Well, most occurred during the first year when I didn't have any influence in that. So as you said, I started working as a medical psychologist and started seeing people with various memory deficits. And one of them was Alzheimer's. And there was a study which I was asked to join, and it was the article we published. Later, we started working at a different department, and that's where I met Dr. Pouwels. So we started talking about the study, which I did in 2011, because it's a newly published article, but the study was done in 2011. And we started looking at all the results we had and just rewrote it. Because we thought, well, this is something that isn't out there yet. Let's bring it out there so people could, do some research and hopefully get the patients with Alzheimer's, which is really, well, if you have it, there's not a lot you can do. So if there's something else that you can do besides getting medicine, well, that will be great. So that's why I put it out there.
I definitely want to get to that for sure. You know, the sort of originality of what you guys did, and at least on a preliminary level, and then kind of this idea of all there is available as medications. But I would love to bring in Sjaak to talk about his interest here as well in neurobiological sciences.
Yeah, the thing is with medicine in general is that we have several diseases we can treat and then people get better. And we have several diseases that are out there and we're basically treating symptoms, and eventually the disease gets worse or progresses or even results into mortality or death. And my interest in particular in neurobiology started with facial plastic surgery, and in particular the impact of a facial nerve palsy or paralysis. And secondly, how does a peripheral condition like the facial palsy influences our brain? And then I started looking for treatment modalities. I started reading about neurofeedback, about training methods to improve or get a get a disease stable. And that's how my interest in neurobiology, neurophysiology came to light.
So that's how you and Robin came together. Can one of you explain what neurofeedback is? We've talked about this a couple times on the show, and I don't know which one of you would like to field this question, but can you kind of briefly explain what neurofeedback is? As I understand it, a few things are necessary to perform neurofeedback. First, you may need to map the brain with a quantitative EEG or a QEEG. Could one of you guys sort of step us through, maybe Robin, you could step us through what's involved in neurofeedback and a QEEG or something like that?
Well, the thing about neurofeedback is that it's like an operant conditioning. So you've got desirable brain activity and we've got undesirable brain activity. So one thing we want to strengthen and the other thing we want to bring down. And that's just what we do. So the brain gives feedback. And with that feedback, we also give, well, in our study, we gave video feedback and sound feedback. So they work together so you get the desirable brain activity.
So this is just to clarify, this is you mentioned the term operant conditioning, sort of like reward, and I don't want to call it punishment, but you can drive the brain's activity in a way that would be sort of a goal state based on what somebody sees on a screen or what they're hearing. So these are the feedback components to their brain.
Yes.
Is that correct?
So our patient had a video, and if the brain activity was what we wanted to see, so we had the higher functioning brain, so the higher amplitudes, then they heard a beep, and then the videos were clearer, so they were less blurred. So that was the feedback they were getting. So the desirable brain activity was rewarded with better image and better sound. Okay,
so maybe we could just maybe even talk on a more introductory level to help us. So because you mentioned amplitudes and certainly there's like speeds and things like that. When you do a brain map, meaning before somebody gets a treatment, I presume they had some type of kind of baseline or before treatment reading. What are the things that you see? Do you see like different brain waves of people? Can you kind of tell us what are the options and what do you see in people that are sort of with Alzheimer's or with cognitive impairment?
Well, what you see when you compare the elderly, normal functioning elderly people with Alzheimer's is that their brain is slower.
The waves are actually slower.
Yes.
And those show up in terms of like differences in delta. Like how does it break down? Is it like delta, theta, alpha, beta type of waves? Like what are the slower waves?
Well, the delta and the theta, they're more, so they need to be decreased.
Okay.
So those are the slow waves.
Okay.
And the alpha and beta, they need to be increased.
So you can use neurofeedback to actually decrease the amount of what we would call abnormal brain waves in the delta and theta range. Yes. And you can increase a human being's activity in the alpha and beta range. And ideally that would end up with better cognitive performance?
Correct.
Wow. Okay.
Yeah.
And so that essentially the design of the study here?
That was what we wanted to see if that was correct. So that's what we know neurofeedback does. And that's what we saw eventually we saw less decrease in the alpha and beta. So that's what we wanted.
Sjaak, maybe I can ask you also a question. Who were the people in this study? Were these people, what age and how sick were they and that sort of thing?
No, basically these patients were having stable Alzheimer's disease at the moment. And before inclusion in this study, we did a multidisciplinary look at with a geriatrician, a neurologist, a psychiatrist, a psychologist, and a nurse. And we did the Cambridge cognitive examination. And this examination was used to basically set off the stable Alzheimer's disease patients. And those patients were included in this study.
Can I ask you about the Cambridge Cognitive Assessment? Why did you choose that tool and how does this in general, and I don't know if this is a better question for Robin, but what is sort of a normal score and how sick were the people in your study?
Well, the score varies from, I think it was from 1 to 100 and with 0 and 1 being really bad. So cognitive decline and 100, there will be no decline.
Okay.
And cognitive functioning. Our patients had a score from 60 or higher because we wanted patients that were in the early stage of Alzheimer's.
So these were primarily, if I recall from reading the paper, these were primarily people that were able to live still independently to some degree, like they weren't full-time care, nursing home, that type of thing.
Correct.
Okay.
Yeah, correct.
And why did you choose those folks as opposed to other ones, just sort of practical reasons, like they had to be able to get to the clinic, or, why did you choose that group?
Well, it was really difficult to get the patients we wanted. So for this study, we only used 10 patients and we wanted really 30 or more. But it was really difficult to get. And we saw that if patients were living in an environment when they were taken care of, it was more difficult for them to come to the hospital. And it was even for people living independently, so people that were able to get to the hospital by their own or with their partner. It was a big thing to do because they had to come 2 times a week for 15 weeks in a row.
And how long does each session last, like when you're doing the neurofeedback training?
Well, the training itself was 20 minutes, and before and after was a brief measurement. But then we had to place all the
leads.
Yes, thank you very much. So that also took time, and then we have to take it off. So it was like an hour, 2 times a week.
So that's a big commitment on behalf of a research subject, for sure.
It is.
And they probably weren't paid anything, really. Maybe just give them parking or something like that, right?
No, they weren't
paid.
No, they weren't.
Okay. And can you kind of explain what you found in layman's terms? And either Robin or Sjaak, you can handle whoever you want to handle that question.
Do you want to answer it, Sjaak, or should I?
Yeah, you should.
Well, what we saw in general is that we saw the cognitive functioning was stable. So there wasn't a decrease, there wasn't an incline, but it was stable. And normally what you would see is a decline between the first measurement, so before the neurofeedback, and after the measurement. And fortunately, we saw stable measurements. So
Did you see any improvements?
There were improvements, but there were in a couple of patients out of the 10. So to state in general that there were improvements, I think it's a lot to say. But there were a couple improvements on the things that improve were orientation in place, past memory, recent memory, and learning memory. But it was just for 3 patients. And overall, we saw that it was stable.
So then I guess there's a question. If only 3 of the 10 patients improved, would those 3 just by chance have improved, right? Like, was this, and the only real way to know that would be to do a split test where you have somebody that's, an equal group of people that are about similar, one receiving this intervention of neurofeedback and one not. Is that correct?
Yeah, what you also could do is measure it in like another year. How is it then? And that's what we wanted to do because it is a pilot from a larger study. Mm-hmm. But unfortunately, the larger study got canceled due to the lack of participants.
Mm-hmm. I see. If neurofeedback were to work, is there a because at the time when this is published, and this wasn't published that long ago, this was a novel contribution. Actually, the person that told me about this work was Tom Kalura with Brainmasters, and I think you used one of their machines for this particular study, if I'm not mistaken. Is that correct?
Mm-hmm. That is correct.
And I mean, at the time, there's a little bit of data out there on folks that are kind of normal aging or at risk for cognitive decline, but this, as I understand it, and still, I think is the only study on people with confirmed cognitive impairment of sort of an Alzheimer's variety using neurofeedback. Is that correct?
To my knowledge, That's correct. Yeah.
So, I mean, that's exciting. I mean, somebody should probably follow up on this work because these results are not trivial.
Yeah.
Not trivial.
Yeah, and I was really sad to hear that the study got canceled because at the moment I'm not working at the hospital anymore. Mm-hmm. So I had a conversation with our second author on the paper, and he told us that, the study got canceled because after 6 years, they still had like 30 patients. So that wasn't enough to get real significant data.
Yeah. So can you give us a sense, and I'm certain that there are political and economic differences in the United States and Europe, particularly the Netherlands, where you guys are practicing. But here, If we could, one of the things we're trying to raise awareness around on this show is just how difficult it is to do studies, particularly that are non-pharmaceutical. The devices, there's a lot of medical devices that are fairly well funded, but it's difficult to get funding for things that are not either a drug or interventional, sort of a device that you can implant or surgically implant. Can you guys talk to how much does a study like this cost, and what are the resources needed for something like this, and why is it so difficult to recruit people? Just some of the challenges around doing research. I know, Sjaak, you're a researcher as well.
The thing is with these specific type of studies is that, as you mentioned, funding or getting funding is extremely difficult because pharmaceutical companies or medical device companies need to see profit or a beneficial effect of their device intervention or either medicine. And secondly is that you need to get the right persons to study. Because if you start a study like this, you have to clearly define what kind of people you're including in your study. And in particular with this study, as I was told by Robin, that you have to start somewhere in terms of this is exciting new evidence. And you have to start somewhere. And that's why we started with more early stage or stable Alzheimer's disease space. And I think especially in cognitive research, those things are extremely challenging. Next to the fact that you need to have a research team, you need to have colleagues that are interested in research, you need to have a good data repository, all that kind of stuff. And that's difficult if you don't have it.
Let me ask a follow-up question on that, because it's interesting when you talk about the research team and the data repository. Have you been involved in studies, either one of you, that have been supported by either a medical device surgical company or a drug company, pharmaceutical?
Yeah.
You have, Sjaak. Yeah.
Can you speak to the difference between organization and personnel and funding in a study like that versus something like this that's an important, in my opinion, important pilot study, but maybe isn't robustly funded or coordinated? Can you, in terms of research and recruiting and the team and just how kind of the speed that the research takes?
The thing is with funded research by pharmaceutical companies is that you need to think about every step during the research, from initial protocol to inclusion of patients. Also, you need to have an external party. In the Netherlands, that's called a monitoring service. Mm-hmm. It's that an external party looks at your data and sees whether it has been stored correctly, has been interpreted correctly, and especially in surgical trials or in medicine trials, is that you need to look at adverse effects of medication, of implantable devices, and you need to register them correctly. And if there are too many adverse events in terms of serious adverse events or just adverse events, then you need to do an interim analysis, whether the study needs to be canceled or can continue, or especially when you're doing funded research, you have a whole structured plan in front of you and you need to use it. And compared to pilot studies like ours, it's basically like we have an idea and how are we going to start with it? And then we start performing the study and it's less structured. That's basically the difference.
So, Robin, you have an idea. And, I like this idea. Neurofeedback I'm thinking it might work in this particular group of people with cognitive decline, people with sort of early Alzheimer's. How long does it take to go from I have the idea to actually starting to recruit people and starting doing an intervention? And I mean that maybe in a general sense, but certainly in this particular case, did it take a long time to get this idea off the ground? Did you have to sell the hospital on it and do a lot of sort of politicking, or was it relatively well accepted and straightforward?
It was well accepted. We had a couple of geriatricians who were really interested. We worked together with the NIN, the Neurofeedback Institute Netherlands, mm-hmm. and where they see a lot of people plainly and mostly for neurofeedback in ADHD, autism, depression, etc., which is all well examined and gives a significant improvement. So we had a lot of data to show. So they were fond of working with us. And in the team, it was always, can we get this patient to participate or can't we? What do we need? Can we look at the inclusion criteria once more? Can we narrow it more? So they were really willing to work with us, but the problem was mostly the commitment the patients had to offer. So going to the hospital 30 times.
To take this in a different direction, have you seen QEEGs at brain maps, meaning what brainwave activity looks like, just in sort of, I guess, simpler terms, on people that have more advanced dementia? Have you seen that where people that already have less independence and may require more kind of assistance just getting through the day? Have you seen what those brain maps look like in any number of events? Have either of you seen those?
Yes.
Let me ask a follow-up question to that, Robin. Do you think, because of the challenge that you had here of getting people to the clinic twice a week to spend essentially an hour with you with all of the pre and post things that needed to be done, do you think there may be a benefit to bringing this into a place where people are already they're a little more advanced?
Yeah, that's what we were looking at. Right? So we had a company in Holland which were enthusiastic in thinking about getting the treatment into the places where the people live. So that were patients with severe Alzheimer's. But it took a lot of time getting a device made which was handleable so we could take it to the patient's house. So we were looking at ways to get more participants, get it easier for them. So
what became of that idea of getting this to the patient's houses that needed? Whatever became of that?
Funding problems.
Okay. So it really all sort of boils down to the same thing, which is recruitment, funding, and personnel, right? Yeah. You can only focus on so many things.
Yeah.
So somebody needs to follow up on this work. So if any of the listeners know anybody that want to follow up on this work, we'll get them in touch with you.
Please.
We'll work on it stateside, because we've had a couple of other people on it that have been on the West Coast and the East Coast of the United States and Los Angeles and in Philadelphia that have been doing some pretty interesting things. Neurofeedback being a part of it, because we're really interested in combined therapy. There was some gentleman on who was using neurofeedback in combination with something called a V-light, which is sort of a low-level laser, or sort of like these infrared light technologies, and that's interesting. Do you have any thoughts on combined therapies? I know you discussed it a little bit in your discussion of the paper. Where you're combining the medications. A lot of people are on called cholinesterase inhibitors, which basically means that they take a medicine to make more of a certain neurotransmitter or brain chemical available. Like, do you have any other ideas about, okay, well, if you'd combine this thing and another thing, maybe we would have an even better result, especially around brain science, brain health, and brain injury and Alzheimer's?
Do you want to answer this, Sjaak, or should I?
Yeah, I would love to. I think the idea is nice to combine medication, for example, cholinesterase inhibitors in Alzheimer's disease with neurofeedback. But before we can introduce these kind of combinations, we need to study them. We need to study them in preferably a randomized fashion, randomized clinical trial, randomized double-blind trial, or a matched prospective cohort study. And so basically, I'm very fond of combinations of therapy in general, if you can investigate it and show that it works. And currently, it's just a speculation. And so basically, I'm very fond of it, but the time will tell us if it works and if it's even being studied, and if people get enough funding to start such a study.
Robin, do you have any thoughts on the idea of combinations of therapies, and what combinations you'd like to see tried?
Well, I'd like to see the patients with Alzheimer's getting more involved in day-to-day life, because that has a lot. If they have an active life, they will be more. Well, they have more capacity to remain the cognitive functions they have. So that was also something we discussed in the article, getting patients to participate, getting patients to go outside, going to the hospital 30 times, excluding the measurements they had to take beforehand, can also give a positive effects on the decline. So that will be also good to see what does physical activity do in terms of cognitive functioning in people with Alzheimer's, next to neurofeedback, next to the medication.
Yes, very interesting. Of course, that's a a good idea for a study for sure. And I suppose you could have built that in even to the way you did this study, meaning I guess some people chalk that up to placebo, meaning you just meet somebody, and part of having a visit and having contact with a clinician, a psychologist, physician, whatever, may have a therapeutic effect in and of itself. So, perhaps you did do a combination study without calling it that, I guess, right? I have another question. I think this would be more for Sjaak, which is, I understand you are currently involved in research on the negative effects of anesthesia, as you are training in surgery, the negative effects of anesthesia in cognition. Can you tell us a little bit about what you've done so far and what you're seeing?
Basically, in my current clinical practice, I see a broad spectrum of patients, from children to octogenarians with different types of problems. And what you do see is that especially the elderly, the octogenarians, you need to prepare them before surgery. And normally we do that with medication. And even though we do that, we still see a cognitive decline afterwards, in terms of patients have a progress stage of their Alzheimer's or their dementia. And secondly, they almost all get a delirium afterwards. And currently in our hospital, we have built a special geriatric trauma unit, which basically combines the forces of surgery and geriatric medicine, just to optimize the treatment for the frail elderly that did have a trauma, a hip fracture, upper arm fractures, foot fractures. And there we try to incorporate social activity, physical exercise. Secondly, also the geriatric point of view is for our geriatric specialists. And also we can give those patients surgical care. And currently we're starting up a project that will assess the effects of anesthesia, and secondly, what it does on cognitive decline in these specific patients.
So is it pretty clear to you at this point that, like you mentioned, many, if not most, patients of a certain age that undergo anesthesia, I'm talking about general anesthesia where you're so-called knocked out, is my understanding, there's a pretty high rate of people getting delirious, actually. It's a change of consciousness and very confused and sometimes combative after anesthesia. That's what you are studying now, right?
Yeah, we're currently in a startup for a few studies.
Can I ask a follow-up? Does it depend on how long the anesthesia was? Do we have any specifics, like for simple things, if somebody's under anesthesia half an hour or an hour, it doesn't matter. But if it's have you discovered any particular parameters that make something more risky?
Risky is not the correct word, but what you need to do is to assess the whole patient. And especially the elderly have not only cognitive function problems or dementia, but also cardiac, pulmonary, or other type of problems that need to be taken into consideration before you give anesthesia. And the consensus currently, especially in the Netherlands, is that if it's possible, you want to give, especially these type of patients, not general anesthesia, but regional anesthesia. Either a block or an epidural or spinal anesthesia. That decreases the risk of, firstly, cognitive decline, and secondly, cardiopulmonary complications. But the thing is, it has to be possible. And sometimes it's not possible due to medication use or just the condition of the patient. Okay.
So obviously, like you're saying, the more fit cardio pumps, so heart and lungs and just sort of general muscle, even if somebody's exercising more. And Robin, I don't know if you have anything to add, but in terms of, somebody's more active with their mind, I would presume, but I don't know, I don't know if it's playing out like this in the research. I would presume that those folks typically do better under anesthesia. Is that correct?
Yeah, I see it on a daily basis.
Okay. Robin, would you have anything to add in terms of things that you would think might be better, both pre and post anesthesia, that might help somebody do better in a sort of a surgical setting and under anesthesia?
I could give some hypothesis, but I haven't gotten into the scientific of it. So it only will be a hypothesis.
Right. That's okay.
Well, I think that if people know what they are getting into and they know the costs and they know the benefits and they are well informed and psychologically stable, and what Sjaak said, they're in the best health they can be at the moment, that will be better for them. So I also think that the psychological state will determine the outcomes of anesthesia. I haven't read into it yet, so don't pinpoint me on that.
Okay. We won't hold you to it until it's studied rigorously. Sjaak and Robin, I really appreciate you making time for us. The work that you've done is really an original contribution, and I really hope somebody is able to follow up on this and do a larger study, perhaps randomized, and so we can make a clearer determination on the role of neurofeedback in cognitive decline, particularly Alzheimer's type.
I hope so.
Thank you so much for being with us.
Yeah, thank you for having us.
Thank you for having us.
And if people are listening all around the globe, if they want to collaborate with us, feel free to email us.
So that's our episode. I hope you guys got something out of that. Check the show notes out on iTunes or on our website where we've summarized the key points. If you have questions or comments or just want to connect, please check us out on our Facebook page. Or if you're old-fashioned like me, Google Evolving Past Alzheimer's Podcast, and you'll find us that way. Finally, if you find the information here valuable, please consider giving us a 5-star rating on iTunes and leaving comments in the comment section. It will really help us bring this message to as many people as we can. Thanks, and talk to you next time.